Good morning, good afternoon, good evening, and welcome to another webinar of the World Stroke Organization. My name is Uta Hanning. I'm an interventional neuroradiologist from the University Medical Center in Hamburg in Germany. And our topic today is imaging selection for acute interventional stroke therapy. So just a little housekeeping before we get started. If you have any questions, please share them with us and type them into the question and answer field box in your Zoom control panel. And we will bring them up during the question and answer session after the presentation. So, and now I'd like to introduce our today's speakers, and we will start with Professor Bruce Campbell. He's a consultant neurologist. He's the head of stroke and interim head of neurology at the Royal Melbourne Hospital. His research interests are focused on the imaging and treatment of acute stroke, and he was the co-principal investigator and medical coordinator of the Extend AI multi-center randomized trials published in New England Journal of Medicine in 2015 and 18. He is chair of the Clinical Council and the director of the Stroke Foundation and co-chairs of the Australian Stroke Guideline Working Party. He co-chairs also the World Stroke Organization Young Stroke Professional Committee and is the coordinator of the National Brain School Training Program for Neurologists in Training.
G'day, Bruce Campbell from Australia discussing my perspective on imaging selection for acute interventional stroke therapy. I have no financial disclosures. I'm going to discuss off-label use of alteplase beyond 3 hours. So what we're talking about is interventional therapies, not just endovascular thrombectomy, but intravenous thrombolysis, hemicraniectomy, perhaps novel therapeutics in a time window 0 to 24 plus hours. And the first question is why we do imaging. First of all, we need an accurate diagnosis. Is it stroke versus a stroke mimic? And if it's stroke, what type of stroke? With selection, we want to think about thrombolysis, thrombectomy, remembering that large vessel occlusion is only about 10% of ischemic stroke and much less than 10% of the suspected ischemic stroke population that we need to image. Are we worried about hemicraniectomy, and perhaps in future do we need other therapies? The real question is, what is the expected natural history versus the outcome if we reperfuse? And all this needs to happen fast, which to me means it has to be standardized and familiar and occur at the initial point of contact. We have a minimum sufficient information to treat approach, parallel processing to prevent delay. So hopefully when the patient arrives, they've been pre-notified and go to CT directly on the ambulance stretcher. And our approach is to do a non-contrast CT, followed by a CT perfusion, followed by a CT angiography upfront routinely. In parallel with that, we're assessing the NIHSS, the premorbid function and contraindications to reperfusion therapies. Clearly, intravenous access for contrast is a rate limiting step, both for CT angiography and perfusion, and that needs to be prioritised in parallel with all this. When we see the non-contrast CT, we exclude hemorrhage, we look at established infarct and hyperdense arteries. And if you see a hyperdense artery with a good scan in the early time window, of course, you're going to activate endovascular therapy at that point, and you're going to start thrombolysis at that point in parallel if the diagnosis is clear. If the diagnosis is not clear, the thing that's going to help us most in making those treatment decisions, in our view, is the CT perfusion. So if we see an arterial territory perfusion lesion and it wasn't clear before, we're going to be confident to treat with thrombolysis. And if it's a large vessel occlusion type perfusion lesion, we're going to activate EVT if we haven't already. The CT angiogram then follows, and that tells us about the proximal vascular access, whether there's a tandem atherosclerotic or dissecting lesion in the carotid, and it helps us plan the procedure, but the decision to treat has already been made. There are multiple approaches to imaging selection. There's a generalizability pyramid, if you like. Some people can go direct to angio, which is fantastic if you've got an angio suite that can be dedicated just to stroke. Most places are not in that situation. MRI is fantastic if you can get immediate access and you have a fast safety screening procedure that's suitable for patients who can't tell you about the metallic implants. So most of us are left doing CT. And I think in this day and age, CT and CT angiography need to be standard for all patients. And it's in the question of, do you add something like CT perfusion on top of that? One of the issues with CT angiography is it may not show you the true site of occlusion or true extent of late arriving collateral flow. This is dynamic angiography derived from a CT perfusion acquisition, which is routinely available. And you can see if you'd have a peak arterial acquisition, you'd say this patient has a right ICAT occlusion with very poor collaterals. But if you follow through a few more seconds, you will see that they have good collaterals. And in fact, if you follow right through to the end of the CT acquisition, this patient doesn't have an ICAT occlusion. They've got a short segment M1 occlusion with some residual flow, and this patient recanalized before they got to thrombectomy just with thrombolysis. And this is the Bejoy-Menon's intersect study that showed that residual flow is a strong predictor of early recanalization with thrombolysis. So CT perfusion raw data is repetitively scanning through the brain as the contrast washes in. You can see there the left hemisphere fills before the right hemisphere, and the insular region is not getting very much flow at all. And we take every pixel in that image and translate it to a concentration time curve. You can see in here the right hemisphere is going to have delayed time to peak, or Tmax, because distal to that occlusion it's got to be filled by leptomeningeal collaterals, which take longer. So this time to peak lesion represents the area that's supplied by collateral flow. It's the area that's clinically symptomatic, and it's the area that's at risk of infarction if you don't reperfuse the artery. The area under the curve is the cerebral blood volume. And I said in that insular region, there's very little contrast arriving. Therefore, there is very little area under the concentration time curve, as shown here. And that area of reduced cerebral blood volume corresponds very nicely to a diffusion MRI that was contemporaneously required in this case. The acquisition is 60 seconds, takes about 90 seconds to reconstruct and transfer, and then you've got 45 seconds automated processing to maps, and that will just continue to reduce as hardware gets faster. The automated processing can apply a CBF threshold. Here's the relative CBF less than 30% threshold, which is commonly used to identify or estimate the tissue that's likely to be irreversibly injured. And this is a Tmax greater than 6 second threshold that estimates the area that's at risk of infarction if you don't reperfuse. One of the key things about CTP, as I said, though, is the diagnostic benefit. So if you see that pattern of perfusion lesion, you know there's an ACA infarct. If you see that, it's a PCA infarct, an MCA infarct that's fragmented a little, a standard proximal M1 occlusion that needs a thrombectomy, and a standard ICA occlusion with ACA and MCA territory involvement that needs a thrombectomy. Not every CTA occlusion, though, does need a thrombectomy. This is someone you'd think would. It's a left MCA occlusion, onset 2 hours ago, no changes on non-contrast CT. But when you get the perfusion, you see that actually the perfusion lesion's in the PCA territory. And this person's deficit was due to thalamic and occipital involvement, not MCA territory involvement, where the perfusion is relatively normal, which indicates a chronic occlusion, not someone you want to stick a wire down the MCA. And there's their follow-up infarct to show it was genuinely a PCA infarct. Lacuna infarction is an area where CTP is more difficult to interpret. Sometimes you will see an MTT prolongation, a CBF reduction that corresponds very nicely with a subsequent DWI, and you can pick that prospectively. Sometimes it's more difficult to pick the abnormalities prospectively. We have about a 50-50 hit rate, and so we wouldn't exclude someone from thrombolysis within 4.5 hours if they have a normal CTP, but a lacuna-compatible clinical syndrome. You see other things on CT perfusion like hyperperfusion, in this case after a seizure with reduced Tmax and increased CBF, and here after spontaneous reperfusion. This patient may still have stroke symptoms, but they don't have a target for reperfusion therapy anymore. Mild stroke is a big problem. 60% of what we see has an NIHSS of 0 to 5, and we know that 30% of them end up disabled. It's probably the patients with vessel occlusions and perfusion lesions that are likely to deteriorate. We know from the PRISMS trial that treating everyone on the basis of non-contrast CT doesn't work, and there is a risk of symptomatic hemorrhage in these patients despite their mild clinical deficit. And TEMPO 2 is an example of a trial using imaging selection, in this case vessel occlusion or perfusion lesion, to identify patients with mild syndromes who are at risk of deterioration and may benefit from reperfusion. Results are eagerly awaited. I'm going to talk about extended window thrombolysis. So this is the EXTEND trial and the meta-analysis we did with ECAS4 and Epithet that really lays the evidential foundation for this treatment. You can see there's a strong benefit overall in excellent outcome and not a significant increase in poor outcome, but it's interesting to dig a little deeper and look at the automated perfusion mismatch group. Patients who met those EXTEND trial criteria had a very strong benefit of treatment with no increase in risk, and the odds ratio compares very favourably to TPA within the 3-hour window. Whereas the patients who did not meet the automated perfusion mismatch criteria had no signal of benefit, and if anything, the results seemed to go in the wrong direction. Now, who are these patients? They're predominantly patients with mild, small perfusion lesions that were visually estimated to have mismatch when they actually don't when you apply thresholds. There are a few with large core, but these patients really don't seem to benefit. It's important to emphasise that advanced imaging is not just about excluding patients. I've just shown you in the late and unknown time window, if you're going to do evidence-based treatment, you need to use some sort of perfusion mismatch software. The mild strokes I've talked about with significant perfusion abnormality are patients that you would be likely to treat, whereas if you just approach the PRISMS trial selection, you would not be based on evidence to treat those patients. low aspects, but only moderate volume non-contrast CT changes I'll come back to. And clinically marginal, outside trials, we have patients with all sorts of premorbid comorbidities and illnesses, and you may not normally treat them, but if you see good imaging, you could get them back to very close to their premorbid function. That may be an acceptable quality of life for them. The diagnostic benefits cannot be overestimated. When patients present, the first question is it stroke, not is it an EVT case? And doing it routinely means familiarity, technical quality and speed. There are variable levels of clinical experience on the ground, both in hours versus after hours and via telemedicine, and the diagnostic certainty you get from a CT perfusion can actually reduce procrastination due to clinical uncertainty. It improves your ability to interpret a non-contrast CT when you've got a CTP telling you the area to look at and focus your attention on. And as I showed you, occasionally large vessel occlusion is not acute and symptomatic. It might be chronic, partial, or asymptomatic, and perfusion can help you identify those cases. Maybe in future we'll have non-reperfusion based therapies that benefit patients who are not going to do spectacularly well simply with reperfusion alone. Repeat imaging is a big cause of delay in transferred patients for EVT. You've got to think critically about whether it's actually benefiting the patient. If you've done complete imaging at the initial hospital, transferred it so the receiving team can see it, then what about deterioration? Well, you can exclude hemorrhage with a flat panel angio-CT. You can identify a target for revascularization with a diagnostic angio if you're worried they might have improved and recanalized. And if they're still within 6 hours, you've got to ask yourself the question, what would change your desire to treat that patient if they've got a large vessel occlusion and they're within 6 hours? And if the answer is nothing, then there's no point repeating the imaging. Of course, some patients are in the extended time window by the time they arrive, and it may have been a very extended transfer, and you may need to repeat at least a non-contrast CT to ensure that they haven't progressed in transit, particularly if their collaterals were not great at the initial centre. This issue of non-contrast CT for irreversibly injured core is very interesting to me. It's insensitive to ischemia early after stroke onset and poor inter-rater reliability even among experts. But it is specific for irreversible injury if you can be confident in loss of grey-white differentiation. We're not talking about sulcal effacement, which is potentially reversible. It's important to remember that the commonly used aspect scoring system is not volumetrically or functionally weighted, and it's mainly relevant to ICA and M1 occlusion. So in the SELECT study, it was interesting to note that 60% of patients with a low aspects of 0 to 5, who might be excluded for therapy under some regimes, had a core volume using CTP of less than 50 mils. In the late window, presentation is often unknown onset rather than truly late. And so we can't tell if they're early and therefore not showing on a non-contrast CT. And there's just at the moment a lack of evidence that a good non-contrast CT is sufficient selection in the unknown time window. And as I mentioned, it may unduly exclude low aspects patients who actually have a small core. Here's the SELECT data showing if you have favourable CT and CTP, you have a very high rate of good outcome. Interestingly, if you had unfavourable CT and aspect 0 to 5, but a favourable CTP, you actually had a high rate of good outcome, whereas if you had favourable CT but unfavourable CTP, the rate of good outcome was much lower. So it would suggest that using both modalities together is going to give you the best chance of selecting the right patients for therapy and not excluding patients unduly. We looked at the prognostic impact of core volume in Hermes patients undergoing endovascular reperfusion. You can see with a small core, very powerful effect. Even elderly patients who might need quite prolonged transfers can benefit and get a good functional result, whereas patients with a large core need to be treated very fast and be reasonably young and robust to get an MRS-02 outcome. But interestingly, if you're prepared to accept an MRS-03, which many people would prefer to be at home needing some help with cleaning and cooking, but not in a nursing home or dead, then if you are fast, you can achieve acceptable rates of an MRS-03 even with quite a large core. So for 6-hour patients, we don't exclude patients purely on the basis of a large core volume. We balance the volume and its location. We're thinking about localized versus distributed brain functions. We look at the expected time to reperfusion and the patient's premorbid status, and if you know it, their tolerance of disability. There are risks of reperfusing large cores. In the Hermes data, large non-contrast CT changes were associated with significantly increased risk of symptomatic hemorrhage, and over 130 mils, there may be increased risk of edema with reperfusion. Now, perhaps neuroprotection will shift that risk benefit, but at the moment, these are the paradigms we're working in. A couple of cases, young fella, 80 minutes after a severe stroke syndrome. In this case, you can see quite extensive non-contrast CT changes already. Here's this CT perfusion showing congruent area using the relative CBF 30% threshold. Now, some people think this early you should be using a 20% threshold, and if you did that in the yellow region, you'd see that would underestimate even the non-contrast CT changes. I'm yet to be convinced about 20% as a threshold early on. Now, he, at follow-up had an excellent outcome after reperfusion, an NIHSS of 1. Now, does that mean he didn't have an infarct? It was all that false positive core. Well, no, he had the infarct that was predicted. It just spared the critical regions of the corticospinal tract and the primary motor cortex, so he was able to walk out of hospital. Another very early patient in hospital stroke 37 minutes afterwards, way too early to see anything on the non-contrast CT, but he has a large CTP core due to poor collaterals. Now, interesting here, the difference between the 20 and 30% thresholds is the pink area, which is all in the cortex. And our experience is that ultra rapid reperfusion, you may salvage some core, but it's generally in the white matter, not the cortex. So again, 20% threshold may not be helping us here. He had the expected infarct in the cortex. He salvaged some white matter. He was able to walk into his review appointment, so he clearly benefited, but he was still globally aphasic. And that's one of the key things. These patients are unlikely to get out of this unscathed, and you've got to think about where the core is and is that likely to be meaningful to them. So take-home messages are that large vessel occlusion is an important but small proportion of code strokes, and our imaging strategy needs to work for all patients, accurate diagnosis being the key while not delaying the large vessel occlusions. We obtain the same information in all patients because with familiarity comes speed, but the information use depends on the context. And we have that parallel minimum sufficient information to treat principle. Large core means not don't treat, but think for just a few seconds about can we potentially achieve a meaningful outcome with reperfusion. And 70 mils versus 120 mils versus 200 mils are very different prospects. You've got to think about, is the CTP and the non-contrast CT congruent? Is this likely to be a case where the particular threshold of CBF or CBV might be important? What is the location of that core? Very important. And really for both non-contrast CT and CTP, we don't want to mislabel patients as large core who are not. So using the information together is probably the best option. Fast large core reperfusion may salvage some white matter, it may reduce edema in some cases, but it generally doesn't prevent a large cortical infarct. And so you've got to think about the outcome depending on the location and the patient's reserve and frailty. MRS3 may well be a very acceptable outcome, and therefore we are certainly open to endovascular thrombectomy in patients with greater than 70 mil core in any time window, but based on the patient's individual factors. And making these decisions rapidly, in my opinion, is better informed by more rather than less information. Thank you.
Thank you very much for this terrific talk, Bruce Campbell. And now it's an honor for me to introduce Mayank Goyal. He's a professor of radiology and clinical neurosciences at the University of Calgary. He holds the Heart and Stroke Foundation Chair in Stroke Research and led multiple global trials in the acute stroke space, such as ESCAPE, SWIFT Prime, ESCAPE NA1, and he's chair of the Hermes collaboration. Has over 300 publications in peer-reviewed journals, and overall he loves teaching and travels extensively around the world, helping with stroke care, organization, workflow, imaging, and intervention.
Good morning, everyone. It's a pleasure to be here with you in this debate section through the World Stroke Organization. And thanks very much for inviting me. These are my disclosures. I do work for quite a few device companies. So as we know, that acute intervention endovascular treatment due to acute ischemic stroke due to LVO, that is very well established. There are 8 positive trials, 7 in NEJM. In the less than 6-hour time window, we put together the Hermes collaboration, which is published in Lancet, JAMA, etc. There is no subgroup where the treatment does not work. And obviously, from a guideline perspective, that has resulted in the guideline change where basically within 6 hours of being normal, CTA MRA is sufficient, and there is no need for doing any perfusion studies. In fact, it is more likely to add confusion rather than add any information. Yes, if you're an amateur and you just are not being able to diagnose LVO, maybe perfusion imaging would help, but that is basically essentially not needed at all. And any step that we do is going to take time. We know that at the current moment, and maybe neuroprotection would change things along the way, at the current moment, the only thing that works is opening up the occluded vessel. And you have to look at every step along the way as just a step along the way to enable you to open the vessel. So doing any additional imaging does not help the patient. It basically sort of, so to speak, kills neurons because you're wasting time along the way. Remember, the brain is not the heart. This guy came on the cover of Time magazine. Dr. Christian Bernard did the first heart transplant. So as I like to say, that he made the heart a disposable organ. There is no possibility of a brain transplant. The only thing that we can do is sort of save neurons. We don't really understand brain eloquence, and this is something that sort of I've been writing about and thinking about for a long time. So just as an example, this person came to us pretty early with a significant stroke, NIH 18-ish, 50 minutes from onset, a young person, 60-year-old, possibly some early changes. But at this stage of the game, it doesn't really matter what the changes are. We're going to go open the vessel 50 minutes from onset. This is the multi-phase CTA. There is a right M1 IC occlusion. The collaterals are relatively poor, but again, it doesn't matter. We're going to go open the vessel. This is the neck angiogram, and essentially went in, got in there. We're still very early in the game, 65 minutes from onset, and get in there beyond the clot, deploy the stent retriever, pull the clot out, and we are 95 minutes from onset. And this person, the next day, this is what the MR looked like, and looks like there's a whole bunch of diffusion change, except the patient was pretty much back to normal. So once again, what do these changes on MR mean? And this is MR 24 hours, not at baseline. And still we don't have a very good perspective of what these MR changes mean. And that led me to sort of put together this worldwide collaboration that we put in, which was recently published in Stroke, which is the whole idea of sort of challenging the ischemic core concept. And we came up with this term, which is severely ischemic tissue of unknown viability, which is recognition of the fact that we don't really understand core, and also recognition of the fact that events happen after our imaging, which is how quickly and how well we open the vessel, that is going to influence the tissue fate. So it's also with that in mind, we came up with this new term. And in fact, in our opinion, we should stop using the word core. So all that red color and green color is actually probably incorrect information. So from that article, there are many such examples. For example, this red color is there. We open up the vessel quickly. The tissue does not die, but more importantly, the patient recovers quite well. So that's something to sort of keep in mind as well as we move forward. And again, there is overall poor correlation, not perfect correlation, between infarct volume and outcome. This is from the Hermes analysis, in which Bruce is a co-author as well, which basically you have all these people with small infarcts who have bad outcome, all these people with big infarcts that have good outcome. That's something to keep in mind. But more importantly, this is again from the Hermes collaboration published in JAMA Neurology. Mirel Bors was the first author. So imagine you have a 50 cc infarct on follow-up imaging, not baseline imaging. And endovascular group patients do better than control group patients. And when we saw this result for the first time, it was kind of confusing. Why is this happening? And obviously, there's a lot of hypotheses around it. But my feeling is it's again related to what is happening at the tissue level when we look at it. So probably what is happening is that at the tissue level, there is more selective tissue loss in the endovascular arm as opposed to the control arm. And that is influencing the final outcome. Now, in terms of the late time window, which is the way that it all played out, we had two studies, DAWN and Diffuse 3. Both of them showed phenomenal effectiveness of endovascular treatment. A couple of things to point out. When I look at these graphs, this is from sort of DAWN, this is from Diffuse 3, both of them are very similar. One thing to remember is they were highly, highly selective. You don't need this much of an effect size. That means they left a whole bunch of patients around which could have benefited from the treatment but were not included. The second thing is how badly the control arm did, 16% here, 13% in the other one. And essentially you don't need too much technologies to sort of beat it. These were the best patients with low core volume, so on and so forth on perfusion imaging. The second part that is there is this was a mixture of patients who were unknown time of onset and truly late time onset sort of thing. So that's the other thing to keep in mind, that there's a difference between the two. Incidentally, in ESCAPE trial, we enrolled patients up to 12 hours. We had 57 patients that were beyond 6 hours, and we had a similar kind of effect size or outcomes in ESCAPE, even though we did not have any complicated imaging selection sort of thing. So that sort of led to at least change in guidelines at the European perspective, which I'll tell you about in a moment. But then this group was put together called the Aurora, and this was presented by Rahul in the European Stroke Conference. We put together all the people who had late time window patients, obviously DAWN, Diffuse 3 being the major ones, and then ESCAPE, positive, and REVASCAT, and sort of looked at the criteria. But the important part is when you summate it all together, the groups were matched in terms of NIH, etc. And the safety analysis were very similar to the Hermes collaboration. But again, if we just did it on aspects, it was positive as well. So you don't need any complicated stuff for patient selection just because they happen to be in the late time window, just because the earlier trials happen to be designed in those 0 to 6 hours, which is an arbitrary time limit anyway. And again, this is the detailed aspects analysis kind of thing. Even in the aspect 0 to 5, there was a trend towards benefit in this Aurora group. So incidentally, from a European perspective, it did lead to at least this part here. The 10 of 11 experts agreed that patients in 6 to 12 hour window, if they fulfill the escape criteria, notably collaterals and aspects should be taken for treatment. So even though dawn and diffuse 3 sort of ended up being a primary studies, that's just how it sort of played out. And the study got finished in like 200 patients or so, which means they were being highly selective. And just remember that at the end of the day, for a typical person with an NIH of 16, 75-year-old who comes in with an M1 occlusion at 8 hours from onset, it is the single worst day of your life. You should not be not treating them just because of some goofy red color map kind of thing. So that's something to keep in mind. So essentially, when we think about decision making, you have to think about essentially the choices are if the person with LVO, EVT, no EVT, wait for more information. As you're waiting for more information, you may falsely exclude the patient, or you may turn the patient to be dead. And then this applies to early and late time window. There's nothing magic about the 6 hour time window. I've written extensively about this thing called denominator fallacy, where I give this Batman, Superman example that you may have already heard about. Imagine 2 cities, Gotham City and Metropolis. Imagine they have 200 M1 occlusions. Batman is a simple kind of guy, is very practical, does CT, CTA, takes 120 out of 200 for endovascular, 60 have good outcomes. So he writes a paper for the European Stroke Organization journal or the GNIS, 50% good outcome, as opposed to Superman does all kinds of complicated CT perfusion-based selection criteria, takes 20 patients for endovascular, out of which 18 have good outcome, 90% good outcome. This would be sort of the non-diffuse 3 criteria versus non-diffuse 3. So essentially, now it seems like that Superman has better outcomes than Batman does. But the real truth is that in Gotham City, 60 out of 200, 30% had a good outcome because 200 patients had M1 occlusion, as opposed to only 9% in Metropolis. And remember, in the late time window, there is really no alternative. Like in theory, there is this possibility of doing flare diffusion mismatch and giving TPA to some patients. But realistically speaking, at the current moment, there is no other possibility of treatment. So if you don't take them for EVT because of not fulfilling non-diffuse 3 criteria, you're treating them with nothing at all. Now, there is this issue in aspects in terms of people say there is inter-observer variability, lack of precision. The first thing that is there is it's very easy to do a high quality CT head, which many people do not do. The second thing is what we started doing is a MIP reconstruction of the sorry about that. MIP reconstruction that enhances the gray-white differentiation and correlation with collaterals. And then the other thing is think Bayesian. Doesn't matter if the aspects is 8, 9, or 10. And the last part that is there is if you're struggling to read the aspects, it's not clear changes, go open the vessel. If you're struggling to read aspects, look at the collaterals, and that is what increasingly our residents and fellows are doing is that sometimes you get a phone call at 2 a.m., M1 occlusion, good collaterals. That's it. Let's go open the vessel kind of thing. So make it simple decision making. So in terms of the 3 C's, what we follow in Calgary, clot, is there a proximal vessel occlusion? We don't like the term core, we use the term sit UV, but bottom line is there a large amount of obvious hypodensity on CT scan? And the key part here is obvious and large amount. And the secondly, collaterals are the collaterals that will keep the brain open while you go open it. And obviously from that perspective, not to worry about timing, contrast dose, radiation, so on and so forth, we find a non-contrast CT, multiphase CT is the right balance between information content, speed, robustness, and availability. So in terms of sort of, the way to think about it is you want to spend the least amount of time. You need a CT angiogram to plan your procedure, document the LVO. You want to keep radiation dose low, low cost, low post-processing. And the bottom line is you don't want to falsely exclude patients who could benefit from treatment. So we wrote about this many years ago in radiology in 2015, and it was used in ESCAPE and ESCAPE-NA1 port trials used up to 12 hours. So now I'm going to show you some data related to the late time window from a multiphase CTA perspective. This has just got accepted in stroke. So this was based on our data set Prove It and Intersect, which was prospective data set. But the interesting part here is that this is the total number of patients, and the green patients, this box is eligible based on multiphase CTA, and the blue ones are eligible based on CT perfusion. So how much bigger the box becomes if you sort of don't follow the CT perfusion criteria. But then one would think, okay, you're taking in more patients, your outcomes would go down because theoretically you're not eligible for it. But at the same time, the outcomes did not change. So the probability of improvement remained the same in those patients which were CTP ineligible, MCT eligible, as opposed to those which were CTP eligible. There was no substantial difference. So bottom line is we would have left a whole bunch of patients who had the potential for improvement had we followed CTP criteria. And as you know, the multiphase CTA was used in ESCAPE NA1, and this just got published in JNIS, where we compared it to DAWN and Diffuse 3. And basically in ESCAPE NA1, we were faster, but most importantly, our TICI-2B3 rate was the same. And in terms of infarct volume, in ESCAPE NA1 was higher, so to speak, but that could be just differences of measurement in terms of what was available to us. But the key part that is there is the outcomes in the late time window of ESCAPE NA1 were identical to DAWN and Diffuse 3, pretty much identical as you see over here, which further says that bottom line is you don't need to use the complicated DAWN and Diffuse 3 criteria, make them more liberal, may take more patients for endovascular treatment in the late time window. So bottom line is be smart and be fast, avoid analysis paralysis. Do you really need fancy color maps that we are not even sure they tell you what is there correctly anyway to pick your EVT candidates? So overall big picture, CT perfusion takes time, takes contrast, takes radiation, and the red color that shows you the core is probably not correct anyway, and the green color that shows you a penumbra is probably not needed anyway. Yes, I'm a big fan of evidence-based medicine, but not as in DAWN Diffuse 3 when the number needed to treat is 3. B, there are no other options. You can't do any other medication. And plus, we are showing you all this additional evidence to sort of convince you that in the late time window, it does not make sense to follow DAWN Diffuse 3 criteria. In the early time window, to my mind, you really, really have to look for a reason not to take a patient with LVO for endovascular treatment. So the question should be flipped around. Now, obviously, we are working very hard on the whole neuroprotection story. We started ESCAPE Next, which is basically similar to the no TPA arm of ESCAPE NA1. As you know, we've had the first patient enrolled. This story is sort of still coming up kind of thing. And let's see where this story takes us. And that may completely change the way that we think about this problem in the near future. Thank you very much.
Yeah, thank you very much, Mayank, for your terrific talk. So I will start with a question for both of you speakers. What imaging or additional imaging do you perform in patients that get diagnosed with a large vessel occlusion, stroke externally in a peripheral hospital, and then become formally a late time window patient while being transferred to the AVT? This is sometimes, in my experience in our hospital in Hamburg, quite frustrating that even if the peripheral hospital is not located very far away, in some cases it takes a long time due to logistic transfer reasons until they reach our site. So just a case scenario, we have a 60-year-old patient with a large vessel occlusion and an M1 occlusion 5 hours after onset, an initial NIHSS of 14 points, aspects of 7 with good collaterals, no CTP performed at the peripheral hospital, and he arrives late at EVT site 7 hours after onset due to whatever reason, and with worsening to 18 NIHSS points, so from 14 to 18 NIHSS points. Would you perform additional imaging, and if yes, and what the most important aspect for to have a standardized protocol for this scenario?
So I'm happy to go first. Thanks, Uta. Thanks for the kind introduction. So overall, big picture, our current thinking is 6 hours is not important. We just don't care about it, kind of thing. That's one thing. The second thing is we are quite centrally organized, and Canada is a big country. So if it's in the city of Calgary, we don't get transfer patients too often. We get transfer patients from out of the city, in which case the transfer time is substantial. So there you have to make a judgment call as to whether you do repeat imaging or not. But the repeat imaging decision is not based on that the previous imaging happened to be at 5 hours and the next imaging is going to be happen to be at 7 hours. That does not form a part of the decision-making paradigm.
So in our context, in our metropolitan area, they would have had the CTP up front and they would have had good collaterals presumably on that too, and we would just go straight to the lab. So that's the way we approach it. We get the imaging at the first place and don't repeat it unless there's been an extraordinary delay, like more than a couple of hours, which happens through our country transfers, in which case we just do the whole thing again because the team would have been called in and they'll just get it on the way up.
Okay, thank you very much. And then a rather hypothetical question, and just a short answer with yes or no will be enough. Since you both explained two kind of different philosophies, could you imagine going on vacation to Gotham City or Metropolis, vice versa, for 2 weeks and perform imaging with regard to the local protocols, or would it make you feel very uncomfortable at this point?
No, because like you always have the option of using additional information and ignoring it.
As I said, I think the important thing is to use the information in parallel so that you make your decision as soon as you can. But yeah, I mean, if all hell breaks loose, you can of course interpret a multi-phase CTA. It's just 3 phases of what we'd normally get 30 of. So it's all possible.
Okay. Thank you very much. So are there any questions from the audience? Darius?
Well, we're waiting for the audience to come in, and thank you both of you for a fantastic lecture as usual. I have a couple for you here. Bruce, you showed a really cool thing that I hadn't seen before. One of the slides talked about an unfavorable non-contrast CT, but a favorable CTP. Can you elaborate? Because typically we think that when you see a bad CTP, you should, or a bad CT, you should see a bad CTP. What happens there?
Yeah, so that was that select study from Amru Siraj's group. And clearly, as I mentioned, aspects is not related to volume very well. So there are plenty of people who lose aspects points for a small region like the basal ganglia. You know, proximal M1 occlusion, you're often going to lose that caudate lentiform and insula, which may have very little functional significance, and it's a small volume and only takes a couple more cortical regions, which may only be partially involved to drop you down to the less than 5 group. And yet the core volume may actually be less than 50 mils. If you outline the actual non-con CT area, it would also be less than 50 mils, but you'd have this aspect score that's low. And those patients did incredibly well. So I think that's what I was saying. If you just use one bit or the other, you're at risk of excluding people either way. And if you use both together, then you've got a much more accurate impression of what's really dead.
And Mayank, in a related question, you showed some very compelling, but a little bit controversial data around the late window of the ESCAPE NA1. Do you think that some of those imaging arguments that maybe are taken at 10 hours, 11 hours, will actually hold true at 20 hours? Or is there something different about the same appearance at those 2 different time points?
So when we were designing ESCAPE originally, and Michael, Andrew, and I were sitting together, part of the reason for going up to 12 hours was to include waker uppers. I do think at 20 hours, you're unlikely to get waker uppers, which means they're likely to be truly 20 hours. So that's one thing to sort of keep in mind. If you're at 9 hours from onset at 7 a.m., you don't really know what time the onset was, which makes it a mixture of early and late patients. The second part that is there is the discriminatory value of CT scan becomes better and better as time goes by. So at 20 hours, what would happen is that the CT scan changes should be, for the most part, pretty clear. So like I said in my slide, if you're struggling to see the CT changes and the patient has an NIH of 17 and an M1 occlusion, might as well go open the vessel if it's 20 hours kind of thing. But if, like in fact, right now, just before this call, we had a patient who was for whatever 14 hours, but the CT changes were absolutely clear at a tandem occlusion. And we decided sort of not to treat based on multiplicity of factors. Like I think one of the things at the expense of sort of repeating it is what Bruce also mentioned, that you have to look at the whole picture, not imaging as an isolation. And in addition to what Bruce mentioned, the expectation of outcome from the patient as well. That is also sort of a critical part of decision making. Imaging is one sort of tiny part of that decision making process, and the idea is to keep it simple and keep it helping people understand that it's a small part, and you have to look at it from the overall big picture of treatment decision making. So one thing to note is that at 20 hours, you're unlikely to have a waker upper, which means it's going to be truly 20 hours.
I'm not sure I completely agree with that, Mayank. Most of the patients I see beyond 10 hours, we don't know when it started. It might be that their family had not come home, or they've been found the next day. And generally anything beyond a few hours is going to be unknown onset for us.
I'm going to give you guys a softball here, because I think I already know how you're going to answer this. If you were to choose between multi-phase CTA versus CTP for the late window, which would you prefer? Bruce?
Yeah, well, that is an obvious question, isn't it? I mean, why would you not do CTP? All the radiographer has to do is press the button, and then you get automated maps a couple of minutes later that don't require scrolling through 3 different time points and trying to compare visually, or maybe you can do some sort of color comparison of the 3 phases, but it's just so much easier and it's so much better temporally and spatially resolved. So I think, this point about it taking longer is really not true. And it's just a hardware issue of making it fast enough, and it will get even faster. And yeah, I think the evidence is with using CTP. And as I said, you can compare your non-con and your CTP. You can take all the information into account and not exclude people. Just because, we have this 70 mils in the trials, as I said, you can go beyond that. That's guidelines don't tell you what not to do. They just tell you what should be done for most people. And then you can extrapolate beyond that based on individual circumstances.
Mayank?
I think the answer from my perspective is sort of clear, so I'm not going to elaborate on that. I'll take that opportunity to, in fact, sort of more so agree with Bruce. It doesn't matter how you do it, what imaging you're comfortable with, how do you sort of set it up that you're super efficient and things like that. What is the overall big picture in your country, in your jurisdiction? How much is the cost availability? Does radiation matter to you or not? So on and so forth. But the idea is to not exclude patients based on a certain hard set criteria that was possibly used in the trials. And I think Bruce is saying the same thing as well. So I think in that sense, we are in agreement. Like obviously, Bruce has a setup where it does not take additional time, push a button, post-processing, so on and so forth. But that's not the reality of the world. The reality of the world is it's difficult to do, it's expensive, it's additional contrast. Very often the post-processing doesn't work. There's movement artifact. There's problems of interpretation. People are looking at the maps on their iPhone and deciding to go or not go without looking at the patient. So the idea is if you have a perfect setup, yeah, you can do whatever imaging you want, and as long as you're super efficient. But you also have to see it from the perspective of the reality in your own jurisdiction, and remembering that EVT is super powerful treatment with very low complication rate.
Excellent. We'll shift the gears here a bit. If you got a small basal ganglia hemorrhage in a patient with LVO, do you still go for it? Mayank?
Like in the sense that from an LVO perspective, the likelihood of having a basal ganglia hemorrhage with LVO, frankly speaking, I've sort of hardly ever seen it. More common situation is you have subarachnoid hemorrhage and some contusion because the patient had a stroke, fell down, and then had subarachnoid hemorrhage and contusion. Yes, that doesn't bother me at all. Just go open the vessel.
What about you guys, Bruce?
Yeah, as Mayank said, it's not a common situation. I think the second part of that question was referring to the fact that it might actually be contrast staining, and that is something that happens when you've done a CTA or a CTP before, and then you re-image them on arrival. You see things enhancing because of the broken down blood-brain barrier. So that certainly shouldn't discourage you from doing a thrombectomy. But
so along the question of the contrast staining and the concept of the contrastoma, so can that contrastoma affect your analysis of the imaging, whether CTP or CTA?
Sorry, in the context of that, whether it's a contrastoma or not?
Yeah, so the question asked is, can you get a contrastoma with a CTA brain? And presumably then that CTA is used in either a multi-phase CTA or a CTP. Does that ever influence things?
I think, again, if the patient's NIH is 17 as an M1 occlusion and the contrastoma is small, you still will probably benefit from opening the vessel. If the NIH is 4, there is unclear this thing in terms of sort of what is causing the symptoms, then it requires a more detailed evaluation. Now, the other thing that is there is I strongly recommend doing CTP before the CTA, because at the end of the day, diagnosing LVO is more important than knowing what's happening to the brain from a decision-making perspective. So if you're doing the CTA first, then the first phase of CTA, you haven't had the opportunity to have a contrastoma unless the patient had a previous CTA at an outside hospital.
Another question is around the real world use of CTP maps. So how often are the CTP maps going to be unreliable in the real world setting?
So in that Hermes study, we had a 2% rate of uninterpretable maps. So I think that's probably our clinical experience as well. I know people talk about motion things, but modern software has lots of motion correction. And if the patients really move their head on every frame, you can interpret it as a multi-phase CTA if you get stuck, but we don't have to do that. I can't remember the last time I had to do that. So
My view is what CTP calls core is unreliable.
I have a offline question that came to me from different means. We have many means of communication here, obviously. What about when you don't have an LVO? So you're not, maybe it's a MEVO, or maybe it's a very distal thing, or maybe it's an embolic shower. What do you guys think is the value of the CTP in decision-making in those scenarios?
Yeah, so from a MEVO perspective, there's two different issues that come in. One is the issue of diagnosis of MEVO, and there is ample evidence to suggest that in a single phase CTA, MEVO diagnosis is somewhat suboptimal, and most of the current techniques of AI-based LVO detection are not doing that well for MEVO detection. So for MEVO detection, in the foreseeable future, one would need additional technology like CTP or multi-phase CTA for detection, diagnosis of the MEVO. Now, the second part that is there is once you've diagnosed the MEVO, should you go open it or not open it kind of thing? And then the tissue that is being supplied by the MEVO, is it commensurate with the patient's symptoms? So from that perspective, yes, the verdict on that is not clear. How much of a detailed imaging do you need? The second part that is there is we looked at it in detail, 20 to 40% of the MEVOs may actually be secondary MEVOs where earlier it was an LVO and has broken up and gone distally, in which case there are areas of tissue that are affected outside of the MEVO territory. So I suspect we will go down the same pathway as we did for LVO, where we'll have sort of a bunch of studies that will look at it from a few different ways. If one could go back and design the entire LVO studies again, what we should have done is done a 2,000 patient study of all LVOs, no imaging. And then we would have probably had a positive study and we would have said, let's just go open all the LVOs kind of thing. So we tried to subselect it based on trying to get positive results in 100 patients or 200 patients. And we will have the same issue with MEVO as well, although that is more complicated because the procedure does become more complicated and the low-hanging fruit is already gone. But I do think we will need additional imaging from the perspective of making MEVO diagnosis easier.
Bruce, what do you think? CTP in non-LVO?
Obviously, that's what we use. And it comes back to what I was saying about having a strategy that works for all comers, whether they've got a stroke or a non-stroke, a MEVO or an LVO or something else. Doing the CT first, making a decision on that if you can, immediately proceeding to a CTP means that you're going to see the MEVO, you're going to know what tissue is precisely supplied by it. It's very straightforward, really.
We have a question about COVID. Didn't see that coming. So has the pandemic changed your everyday practice? And how old was the youngest and the oldest patient that you have treated? I don't know if that's youngest and oldest with COVID, but let's just do both. Mayank, go for it. Your mic's on.
So from a COVID perspective, the only thing that is there is we have an angio suite, so to speak, is the COVID angio suite. We assume that every person coming through emerges COVID, and we wear an N95 mask and so on and so forth. Other than that, nothing else has changed. The other part is families are not allowed inside the hospital, so the consent issue is slightly different, especially for trial enrollment. From the perspective of oldest and youngest patient, I personally treated, I think, a 97-year-old. I know Dar, you guys in Escape NA1 had treated a 101-year-old or something like that. I can't remember.
104, Mayank.
104-year-old, and we sort of had that discussion at that time when you guys were part of Escape NA1. From the point of view of the
She was a good 104, Mayank, in my defense.
Yeah, no, obviously it has to be sort of a good 104, and there's this whole issue of sort of the biological age versus chronological age, and how do we quickly discriminate that? From the perspective of the youngest patient, obviously that is in the pediatric population for which there are very poor guidelines and stuff. So I don't remember the age offhand, but I think it was a 14-year-old that I've treated. So,
Bruce, how are things in Australia with COVID?
Look, we've been very fortunate. We did have a brief wave where I am in Melbourne, up to 500 patients a day, but compared to what I see everywhere else in the world, we've been very fortunate. So it hasn't, we haven't had a COVID patient with stroke, but certainly the fear of COVID has changed the system. We've had differences at triage and emergency taking longer. We've had difficulties with our anaesthetic procedures. There's unfortunately been a shift towards a lot more general anaesthesia just to control the situation. They feel that doing a crash intubation in the middle of a procedure would be the worst possible outcome. So that's led, unfortunately, to more GA, and that causes delays. And as Mayank said, not having family around makes a difference in how you discuss these things. terms of age, we don't have age limits at either end. I think by, just looking at functional criteria, I don't think we've gone over about 92 or 93. We just haven't had someone who's a good 95-year-old or 104-year-old, but we also get referrals from the pediatric hospital. So we've had 10 and 12-year-olds and things like that.
Bruce, while I got you on the mic there, what do you think about posterior circulation strokes with and without last on basically with no, what's the time windows here when you don't know, and does the imaging help you there?
That's a really good question. I mean, basics has thrown a little bit of confusion into the mix because we'd felt pretty confident that the dire natural history of basilas gave us a justification to treat people up to around about 24 hours. And we still do. We're waiting to see the details of that publication, but imaging selection in a posterior fossa is a little different. Obviously, we do CTP and you can get a good idea of what's happening in the cerebral hemispheres, but we don't really get a good idea from non-con CT or CTP what's happening in the brainstem, which is the most eloquent area. So we tend to give people the benefit of the doubt. If they've got a blocked basilar and it's not clearly all over, we'll open it up and see how we go.
Mayank, what do you think of the posterior circulation?
Well, posterior circulation, broadly speaking, and the way to think about it is either it's like a vertebral artery dissection with an embolus that has gone up, that is typically at the top of the basilar, or it's intracranial atherosclerotic disease, which is sort of mid-basilar. And then the second part of the decision making is the person relatively fluctuating low NIH awake, or does the patient came in intubated comatose? And based on these two factors, ultimately the way that it plays out is it's a bad disease, especially at the top of the basilar, especially if the patient is comatose. The second thing is that the imaging is not discriminatory enough to know which are the ones that are clearly bad. So give the benefit of doubt, open the vessel. At the same time, when I'm in terms of putting intracranial stenting and things like that, there you just have to be cognizant of that you're trying to go through tortuous vertebral artery, going in there and trying to open a mid-basilar atherosclerotic disease. What you don't want is to have a complication, especially in a person who's relatively mild. So overall, big picture, again, imaging, I don't think sort of changes that much. Our standard protocol is CT multiphase CTA. It does not alter based on posterior circulation stroke. I do think the clinical scenario of what you're up against, mid-basilar versus distal basilar, embolic versus local, comatose versus relatively awake, those factors play a significant role in your approach and decision making.
Thank you very much for that. There's one over here. Well, there's a couple of some interesting ones over here. This one is more of a, I guess, political, but we got at least one speaker or one attendee saying that they're having some hurdles in getting the multi-phase CTA accepted by their neuroradiologists because of acquisition time, training, learning of the interpretation, etc. What resource do you guys think is the best for some of our attendees to use to make change locally at their institutions?
Well, in general, one thing that is there is if you forget about the acute stroke scenario, minor strokes, so on and so forth, interpretation of multi-phase CTA is easier than single-phase CTA just because you have the two extra phases, easier to diagnose MEVO and so on and so forth. The second thing is we do have resources available through our website on the trials website in terms of sort of how to set it up. Third thing is that if you happen to have a GE scanner, GE has a software called Fast Stroke, which automatically sort of sets it up. I think Siemens will have it shortly as well. So those kind of resources are available. And then finally, I do have a talk somewhere on the web, which I can send a link to in terms of sort of on this idea of multi-phase CTA, because we are helping all our sites in Escape Next currently setting it up.
Bruce, this might be a question more for you because I think I already know what Mayank's going to say, although I'm happy to be surprised, Mayank. If you have a CTA and a CT, shows an LVO, but the CTA looks great in terms of the collaterals, the CT and the CTA's contrast / gray white matter looks great too. So basically favorable. Do you still go to CTP? That's in the scenario where CTP is not done automatically anyway.
Yeah, well, that's not the scenario we're in. I mean, I guess if you're in the Mayank paradigm, you don't need to, but we would have done it already, and that's how we would have diagnosed the LVO. And the only time you get surprises is like that case I showed, where there's a chronic MCA occlusion that's not actually symptomatic. And that's where you get, I think the person was talking about false negative CTP. If you've got good collaterals and a true occlusion that's acute, you will see a CTP lesion. There's no such thing as a false negative there. It's only if it's chronic and it's fully compensated that you'll not get a perfusion lesion.
Probably no surprising answer from you then, Mayank. You're good with the CT-CTA.
Yeah, in the scenario that you're describing, like one thing you have to remember is, even though in my talk, I said multi-phase CTA, but very often single phase will work as well. Like remember, in the scenario that you're describing, the focus should be on opening the vessel as quickly as possible.
A little bit of a lateral question over here about calcified clots. If you're seeing a calcified clot, do you guys change your strategy in terms of the EVT process? Probably more for you there, Mayank.
Like in the sense that from a calcified clot, no. So overall, big picture, we've seen calcified clots that open up totally easily. We've seen non-calcified clots that do not open up easily. So it is one factor among many factors that decides how easy it is going to be to open the vessel. In general, if you're on a calcified clot scenario, I do think the combined approach of aspiration and stent retriever probably works the best. We have some data which we are submitting shortly, but I do think the majority of the stent retriever should be beyond the clot, which means if, let's say, you have a 3 centimeter stent retriever, place the calcific portion in the proximal 1 centimeter so that 2 centimeter of it is sort of beyond the clot kind of thing. So that's the other thing that I use as a strategy. And that way you get sort of better local aspiration as well if you take your aspiration catheter right through there. The last part I want to mention is that the technology of EVT is still undergoing massive change. So I do think the way that we'll do EVT 2 years from now will be very different from the way that we currently do it. I do think aspiration catheters keep getting bigger and bigger. And this idea of clot ingestion is happening more and more. And I think that will continue to advance. And once you got to the stage of not clot aspiration, but clot ingestion, calcification might become inconsequential.
We're coming down to the end of the hour, and I'm going to be getting my colleague Uta to wrap up. But before we go, maybe I can try and combine a couple of questions here. We have questions around collaterals and looking at collaterals, comparing multi-phase CTA with single-phase CTA and CTP. And if I could throw in another item here that one of our attendees bringing up, what if you got a situation with heart failure, so decreased cardiac output? How does that affect your CTA, multi-phase CTA, CTP analysis, and the collateral assessments? Mayank, you want to start?
Well, we do have a protocol in our scanner in which if there is a suspicion of low cardiac output, so rather than 3-phase, we do 4-phase. The practical side of it is it never gets used because you don't know in advance that the person does have. So the second part of it is that very often you can make it out because the second phase looks like the first phase and the third phase looks like the second phase kind of thing. The third part is, at the end of the day, what difference does it make? The issue you have to make is open the vessel, not open the vessel. So if the patient is generally worth fighting for, it's an M1 occlusion, NIH of 17, doesn't have a clear wipeout, what difference does it make? Go open the vessel kind of thing. So it does not substantially influence from a practical standpoint. Obviously, if the heart failure is so bad that you're concerned about the overall well-being of the patient based on, like we discussed before, look at the patient as a whole, then obviously, yes, you have to sort of keep that in mind.
Yeah, so from our point of view, if you've got a 60-second acquisition, I haven't had a heart failure patient who hasn't had enough bolus go through in that time. So I think as long as you're not doing a standard, I know Siemens default is 40 seconds, that's probably a bit short. So 60 seconds, you can slow down the acquisitions towards the end, so you reduce the radiation dose and then you'll be able to interpret. And in terms of CTP interpretation versus collaterals, as long as you've covered enough of the bolus, it's the same process, you can interpret either.
Excellent. Thank you, guys. We'll hand it over. I know there's still more questions. Sorry, our time is running out here. So I'll leave it to Dr. Hanning here to wrap up.
So thank you very much, both Bruce and Mayank today. And I would like to remind our viewers that a recorded version of this webinar will be available on the homepage. And for updates on the webinar series, please check our homepage and our Twitter accounts. And thank you again for joining us. We will hope to see many of you back with us at the next webinar on January the 20th about management for stroke with both atherosclerosis and AF mechanisms. Thank you very much and have a nice evening.